Great. Thanks, Gus, and thanks to the Glaucoma Foundation for putting on this great meeting. And greetings to the live audience and greetings to the online audience. Those are some great lectures. And I'm going to talk about some technologies that I would doubt you're using in practice, but I also expect you will be using in practice. Optical coherence tomography, angiography, and retinal nerve fiber layer texture analysis for glaucoma. And I'm not even sure that you've heard of both of these technologies. So I'll explain them both and tell you how you might be using them in your clinical practice. And I consult for a number of companies and receive some research support. I'm not going to be really talking about anybody's specific technology, but if you have access to an OCT, most likely you'll be able to perform OCT angiography. Does everybody have access to an OCT in their practices? So some of you might be performing OCT angiography. Well, David Wang, Oregon, was the first to describe that OCT angiography can detect glaucoma. And he did that 12 years ago. And there's a number of reasons why it really hasn't gained any traction. And a lot of it has to do with the technology that was available to perform the testing. But with the technology that we have today and the modern OCT devices that we use in our clinical practice, you should be able to perform it. FDA has approved some of the algorithms on some of the instruments, and soon they'll approve more algorithms on additional instruments. There's been traction in the research community, in the clinical research community. On the left, you can see publications on OCT angiography. And on the right, you can see publications on glaucoma and OCT angiography. And interestingly, I was surprising, it might be due to the delay in getting things published. It continued to climb, and the delay most likely was from the pandemic and the ability to get patients in for testing. So is it useful for detecting early glaucoma? And the answer is it is useful in early glaucoma. If you look at the circumpapillary vessel density or capillary density with OCT angiography, which is one of the parameters that's measured with this technology, it's more pronounced than retinal nerve fiber layer thickness loss. On the top, you have capillary density, and you can see on the left of that curve, it's picking up glaucoma earlier than picked up by looking at the retinal nerve fiber layer thickness with OCT. 1/3 of the early glaucoma eyes show a greater percent loss of macular vessel density than changes in GCC thickness. And this is a theme that will arise in many of the things that I'm going to be talking about. And Jeff emphasized it in his lecture, is the importance of looking at the macula in glaucoma. David described going into practice in 1995 here in New York. And at that time, I would have expected if somebody said to him, you need to look at the macula, he would have thought they were crazy or they were somebody who was a retinal specialist and trying to tell him that glaucoma people didn't know anything. But it's really important to look at the macula in glaucoma, and the work that's been done by Don Hood and Jeff and Gus in New York is so critical to our understanding of looking at the macula, whether you're doing it with visual field testing like 10-2, where you can look at the macula, or you're going to be using some of these other new technologies. One of the other things that keep in mind is when you do look at the macula, there are racial differences. In fact, if you look at vessel density, VD, when you look at that in individuals of African descent, it's not quite as good as it is in looking at individuals of European descent. I think with all these technologies, the thing that we're all struggling with is how do you use it for monitoring glaucoma? It's one thing to diagnose glaucoma, and that's terrific. In glaucoma, we diagnose, we stage, and we follow patients. But what we really need to do is monitor glaucoma, because we need to understand those patients that are progressing and progressing sufficiently quickly so that their vision-related quality of life might be impaired during their lifetime. So serial OCT angiography measurements detect glaucoma change in macula vessel density in eyes without change in GCC thickness. And that's a recurring theme. Whenever we look at OCTA vessel density over time, we see that there's a substantial cohort of patients in whom it changes before we see structural changes in the retinal nerve fiber layer or in the optic disc. In fact, we see that the rate of macular vessel density loss also is faster as glaucoma worsens. And that's also important because we want to be able to advance our therapy in patients in whom it's getting worse. And typically we see about a quarter or a third of our patients, whether they're suspect or whether they're glaucoma, they have significant loss of their vessel density than changes in OCT, GCC thinning. This is a relatively recent paper, 2023, where we looked at the detection and agreement of event-based OCT and OCTA analysis for glaucoma progression. And interestingly, there wasn't really great agreement between OCT and OCTA, but when you put them together, they provide complementary information about glaucoma progression. And that's how we're positioning it in our own practices, is that it's complementary. It doesn't replace it. It's really complementary, and that you need to do both. And in fact, when you look at how good is it when you perform both of these tests, you could see in blue on top, when you're looking at the ROC curves, that combining the two does better than any one individually. Here's some examples of how you can use this in your clinical practice. And one of the big challenges that both Jeff and David mentioned is, how do you manage patients with advanced disease? And here's a typical example. You saw it in both their lectures. On the left, we have a patient with I think we'd all agree, is severe visual field loss. And when you look at the RNFL thickness map, you can see that it also looks quite advanced. And here on the right, you see that the visual field has clearly worsened. Superiorly, there's almost complete loss of the superior hemifield. However, when you look with OCT at structural parameters, you don't see really much of a change. And that's why both Jeff and David said that OCT is not great for looking at advanced disease. David emphasized in his lecture, when he had his little check boxes, that he tends to look at visual fields rather than OCT. Well, one of the big advantages of OCT angiography is that it doesn't have a detectable measurement floor. OCT, as it worsens, it reaches a point where if you're looking at retinal nerve fiber layer thickness, you don't see much of a change with conventional techniques. And that's called a measurement floor. It's not exactly known why you get to that floor, but there is a measurement floor where it doesn't worsen, even though the function is worsening. Macular vessel density with OCTA does not have a detectable floor, even when the field is very, very bad. You could also use deep learning strategies, to look at OCTA results. Jeff talked about predicting. You could predict visual fields from your structural measurements. You could predict structural measurements from your visual fields. And applying deep learning strategies to OCTA imaging enables the estimation of visual field loss from OCTA images with high accuracy. Here's some other examples. This is on top. We're looking at another patient, and I think most of us would agree that the visual field is worsening over time. And if you look on the right, you'll see what's happening to the visual field. You'll see what's happening to the retinal nerve fiber layer thickness. And then you look also on the bottom row of patient 1, you'll see what's happening to the vessel density. And you see that vessel density continues to worsen. If you're looking solely at retinal nerve fiber layer thickness, it tends to plateau. And so there's a better relationship between the visual field worsening and changes in vessel density with OCTA than there is with thickness. Patient 2 is something very similar. On the top of patient 2, you could see the angiography results. And on the bottom, you could see the GCC structural results with OCT. And you see that they're not changing very much, whereas if you're looking at the parafoveal vessel density, labeled as PF vessel density, it's changing over time. So is it useful for risk assessment of glaucoma progression? Again, in glaucoma, we diagnose, we stage, we follow, and we also use risk assessment. So vessel density is a risk factor for retinal nerve fiber layer loss. There's an increase in microvasculature dropout area associated with progressive retinal nerve fiber layer thinning, as shown, on the right. And when we look at the rate of initial capillary density loss on risk of visual field progression, we see that there's a rapid initial optic nerve head capillary density loss from OCTA, which is more strongly associated with a faster rate of visual field progression than the rate of OCT thinning. And again, 1/3 of eyes with fast OCTA and OCT progression develop subsequent visual field progression within 4 years. So it's pretty good for progression and assessing risk. This is a very interesting paper published by, the group is really Harsha Rao out of India, and looking at progressive vessel density reduction with OCTA in glaucoma eyes with disc hemorrhages. And interestingly, you see progressive nerve fiber layer and GC-IPL loss when in the sector of a disc hemorrhage, but there's progressive peripapillary and parafoveal vessel density reduction in both the disc hemorrhage and non-disc hemorrhage regions, suggesting that even though there's a disc hemorrhage and things are worsening there, with OCTA, it shows us that things are probably worsening even where there is no disc hemorrhage. Another interesting use was reported out of China, where they used OCTA to try to distinguish glaucomatous optic neuropathy from compressive optic neuropathy, a neurologic condition, neuro-ophthalmologic condition. And they thought that compressive glaucoma-like excavation can be effectively distinguished from glaucomatous optic neuropathy with OCT angiography, especially when you're looking at the superficial vessels. So why isn't it used? Why aren't you using it? And what are some of the problems with it? Well, one of the problems has been that there's artifacts. Even with really very skilled technicians performing it, we get about 1/4 of our patients have artifacts. We need higher resolution images. We can get rid of artifacts perhaps with some eye tracking, which is being introduced now in a number of instruments. If you have a spectralis, it's been very slow to acquire the images, and it really hasn't worked well, although the new instruments are much more rapid. If you have a Maestro, for example, it's pretty darn good. The retest variability has not been good, and we need clinician-friendly results. You don't want to look at types of graphs that we have. But we think, the way to perform these is with wide field imaging. The larger the field, the better. we saw, David showed one panoramic view with, I think it was a Cirrus, where you get an image of the disc, you get an image of the macula, and then you put them together. Now there are instruments where you get them simultaneously called wide field imaging, and that's much, much better. You know, it's much better for all imaging, but especially for OCT angiography. And I know a lot of optometrists have a Maestro, so you already have that capability. We think 2 times testing per year provides good information. Doing more testing is not going to be helpful, and doing less testing once a year doesn't provide you with the information you need. I'm going to quickly just go through another new technology. Here, this is the OCTA summary, where, again, it's useful today for monitoring progression with advanced glaucoma, could be used with risk assessment and distinguishing glaucomatous from non-glaucomatous optic neuropathy. Also very useful for myopia. I'm not going to go into details on that. But it's a work in progress, and we need improved technologies. This is another technology that was largely developed in Hong Kong by Chris Leung at the University of Hong Kong. We published our results in Nature in 2022. And it's a quite interesting technology where we use retinal nerve fiber layer en face imaging with the OCT and use some algorithms to look at and extract information about reflectance values and come up with images that show things that we've never seen before. What you're looking at here are retinal nerve fiber layer, or ROTA, defects. In fact, in early glaucoma, the papillomacula defects occur in about 2/3 of patients, and in about 1/6 of patients, we see papillofoveal bundle defects. And these are things we've never seen before with retinal nerve fiber layer images. David Greenfield showed a fundus photograph of a patient. He didn't think there was a retinal nerve fiber layer defect. When I looked at that, David, there was a big, broad retinal nerve fiber layer defect on the fundus image that matched the visual field. And with ROTA, you would have seen that. But what we're seeing are these new defects, perifoveal defects, it wasn't glaucomatous, okay. And then here, you can see these types of defects. You've never seen these, but we've never seen these before. Arcuate papillofoveal defects and horizontal papillofoveal defects. And that, I think, explains why the structure-function relationships early in disease aren't always as good as we'd like them to be. Here's some examples. On the left, we're looking at what looks like a pretty good field. On the top row, we're looking at high-resolution monochromatic retinal nerve fiber layer photographs. And on the bottom, we're looking at ROTA images. And again, these are obtained right off your OCT, it's just some simple software adaptations. And if you look on top, you can see perhaps a retinal nerve fiber layer defect infratemporal. And on the bottom, you can see how it's really amplified by ROTA. If you look at the second column, you see again an image. Perhaps you can see the retinal nerve fiber layer defect inferiorly. Superiorly, it's a little challenging to see. But with ROTA, you're seeing very clearly inferiorly, and then superiorly, you'll see also the arcuate defects. In the third column, we're looking again at a retinal high-resolution monochromatic retinal nerve fiber layer photograph that had been popularized, 20 years ago and abandoned because of the difficulty of doing them through small pupils and, in eyes with cataracts. But take a look at these amazing retinal nerve fiber layer defects that are showing up that really show you why you have that visual field defect inferiorly. And then on the fourth column, again, you're looking at the retinal nerve fiber layer photograph. Nothing very exciting going on there, but look at the ROTA image. All those retinal nerve fiber layer defects explaining those really awful looking visual fields. This is a paper that just went online comparing ROTA images in 10-2 visual fields. And it does provide us a lot of new information where we can now use ROTA as a guide for supplementing 10-2. And again, I congratulate the team here at Columbia, Don, Hood, and Jeff, and Gus for the work that they have done with 10-2. But now we're able very clearly to see some of these structural relationships and how they nicely blend in with 10-2. If you look at these images in the upper left, you're looking, that's a ROTA image, and you can see those defects there, superiorly and inferotemporal. If you look in the middle row, you can see a papillomacula defect, which you would not see in a retinal nerve fiber layer photograph because it's too thin and you don't get enough reflectivity. But one of the things that's interesting is how it maps so well to 10-2 visual fields. In fact, if you go to the bottom right, you can see a visual field that is very, very advanced. There's some function there, but then if you look at the right image, and you place the visual field on the ROTA image, you can see that in fact the ROTA image it's almost point by point, showing you the remaining retinal nerve fiber layers. This is also a technology that can be used with myopia. Sasan Mogimi, who you're going to hear from later, he has a new clinic for patients with myopia and glaucoma, which is it's a epidemic in our population. Patients with very high myopia, and do they have glaucoma or not? Here's a patient with a long axial length, and you can't really evaluate the retinal nerve fiber layer here, can you? Or can you? Well, here are visual fields, right eye and left eye, showing two fields over time. And here's OCT, not very exciting. Remember, OCT in patients with lengthy axial length is very challenging to interpret because of the displacement of the peaks. You can see on the right, and this was shown in prior things, you can see there might be a little change superiorly, but here's what happens over time. These are ROTA images. You can go and use your software to reevaluate images there. You can see changes in the image over time, and then you can see how it just really maps very well to the visual field change. And you can follow myopia patients like that. So we have a team that works on OCTA and ROTA. I appreciate that. We have collaborators, both, in the U.S. and outside of the U.S., and grateful, for the amazing fellows that we have at UCSD. And in June of 25, we're opening our new Vision Research Center. We're very excited about that. And thanks again for the invitation to participate.